Welcome to the Culture of Healthcare, Evidence-Based Practice. This is Lecture B. The component, the Culture of Healthcare, addresses job expectations in healthcare settings. It discusses how care is organized within a practice setting, privacy laws, and professional and ethical issues encountered in the workplace. The objectives for evidence-based practice are to define the key tenets of evidence-based medicine, or EBM, and its role in the culture of healthcare. Construct answerable clinical questions and critically appraise evidence answering them. Explain how EBM can be applied to intervention studies, including the phrasing of answerable questions, finding evidence to answer them, and applying them to given clinical situations. Describe how EBM can be applied to key clinical questions of diagnosis, harm, and prognosis. Discuss the benefits and limitations to summarizing evidence. Describe how EBM is used in clinical settings through clinical practice guidelines and decision analysis. This lecture presents some definitions of evidence-based medicine and describes some of its applications. This diagram appeared in a paper by Mulrow and colleagues in 1997. It puts the use of evidence in the proper context. Basically, evidence is one of three aspects of what goes into making a clinical decision. First, we need to know what the research shows, the results of studies such as randomized trials and systematic reviews. But there are other factors that go into making a clinical decision. A second aspect is factors about the patient and/or the physician, such as cultural beliefs, personal values, experience, and education. Patients may have preferences. In addition, the patient's physical reaction to treatment and medications may also play a significant role in clinical decision-making. Physicians may have limitations in their skills, particularly if they practice in rural areas or places where the entire spectrum of medical services is not available. The third aspect of making clinical decisions is constraints. Formal policies and laws, as well as community standards, may influence decisions. Time may also be a constraint. For example, if a patient is acutely ill, there may not be enough time to do what the absolute best evidence would support. Then, of course, reimbursement issues, such as what medications, treatments, and tests are covered by a patient's insurance, present further constraints on clinical decision-making. Many resources are available to support evidence-based medicine. They not only describe how to practice it, but also demystify a lot of the ideas and techniques behind it. One of these is a book by Strauss and colleagues, informally known as the Sackett book, because it was the original book on evidence-based medicine authored by David Sackett of McMaster University before he retired. Strauss is now the editor of the book, which is in its fourth edition. Two books by Guyat and colleagues, including several authors from McMaster University, originated as a series of articles published in the Journal of the American Medical Association, or JAMA, under the broad heading of User's Guides to the Medical Literature. In 2015, the third edition of these two books came out. The first, subtitled A Manual for Evidence-Based Clinical Practice, is an encyclopedic reference to the clinical applications of EMB. The second, subtitled Essentials of Evidence-Based Clinical Practice, is a condensed handbook that covers the most clinically relevant content of its parent manual. Plenty of websites also offer information on evidence-based medicine, some of which are listed here: www.cebm.net, www.cche.net, and www.nettingtheevidence.org.uk. Evidence-based medicine has been evolving for nearly 3 decades. A paper in 1999 by Hirsch observed this trend, referring to the initial approach to evidence-based medicine as first-generation EBM. The concept was that a clinician would actually find and critically appraise evidence as he or she was applying it in the clinical setting. The clinician would go out, find the article, critically appraise it, and then make the clinical decision. It became readily apparent, however, that the process took too much time, especially in the busy clinical setting, and that not all clinicians had the expertise to really understand study design, the nuances of statistics, and so forth. The more recent approach, the next generation of evidence-based medicine, focuses on synthesizing and synopsizing evidence and making it available to clinicians. The goal is to provide up-to-date information accessible online that assists the clinician in decision-making. Slauson takes this a step further, arguing that we should not be discussing the different kinds of evidence and how to critically appraise it, but instead we should put more emphasis on teaching clinicians better information management or information-seeking skills. Another viewpoint concerning evidence comes from Brian Haynes, whose name you will see throughout this unit. The kinds of questions that we think about when we apply evidence or when we assess a treatment or a diagnostic test are, can it work, does it work, and is it worth it? The first question we ask about a study is, can it work? Studies that investigate whether something works are typically called efficacy studies. These studies take place under ideal conditions, such as in a randomized controlled trial. The participants are followed closely and a great deal of data about them is collected. Efficacy studies help us determine whether tests or treatments work. Evidence-based medicine focuses primarily on those kinds of studies. The next question is, does it work? Often called effectiveness studies, these studies investigate whether something works in the real world when put in the hands of a much larger segment of the clinical provider population. The final question in this framework is it worth it? To answer this question, cost-benefit or cost-effectiveness studies are done to see whether the benefits are worthwhile in relation to the cost of a test or a treatment. Another way to look at evidence is to look at the hierarchy of evidence. One approach shows the different types of evidence that clinicians use for decision-making. This model was developed by Haynes and originally started as the 4S model, the simplest version. He subsequently divided some of the levels into additional levels and updated the model to 5S and then 6S. But the basic 4S model is the most popular. The foundation or first level of evidence is studies, original research that's published in medical journals. For many topics, especially common diseases and common treatments, there are numerous studies, so we need to synthesize them. Thus, the next level in the hierarchy is syntheses. The best syntheses are systematic reviews. Also called evidence reports, they systematically review all of the evidence for a given clinical question. Syntheses, however, can be quite lengthy, and a busy clinician usually needs to understand the gist of the evidence. Thus, the next level in the hierarchy is synopses, which are sometimes called evidence-based abstractions, where key points are abstracted from the comprehensive syntheses. Finally, the highest level of evidence is systems, where there is actionable knowledge, or knowledge taken from the synopses that can be put into a logical form and used, ideally by electronic systems, to automatically guide decision-making. Where does the evidence come from? Depending on the level, there are different types of evidence, and in the slides that follow, we discuss a number of these in detail. Starting at the level of studies, this evidence generally comes from the medical literature, usually by accessing databases such as Medline, which contains bibliographic references to millions of journal articles. Medline can be accessed in many ways, but the most common way, which is freely available, is through PubMed, which is maintained by the U.S. National Library of Medicine. Relevant studies are gathered from the literature and critically appraised. Various formulas such as relative risk, sensitivity, number needed to treat, and odds ratio formulas are used to derive specific information from the studies. The syntheses level typically consists of systematic reviews or sometimes evidence reports. These are exhaustive reviews of the data on a given topic. Where appropriate, meta-analysis is applied by combining the results of multiple similar studies into a single analysis. The combined studies have to be appropriately similar for meta-analysis to be valid, and methodologic means can be used to assess whether studies are similar enough. For example, if there have been 15 different clinical trials looking at surgery or medical treatment for back pain or a specific type of cancer, and they have similar interventions as well as similar patient groups, then we can combine them in a meta-analysis. Meta-analysis can be done not only for treatments, but also for diagnostic tests, prognoses, and so forth. Systematic reviews are available in PubMed and in the specialized PubMed Health database, which is limited to systematic reviews. Synopses, then, are summaries of information that is pertinent to the clinical setting. Synopses provide answers to specific questions. If a clinician in a busy clinical environment has a patient with low back pain, he or she wants to know what the evidence shows for available treatments. The clinician doesn't necessarily want to know all of the many different studies that have been done or how those studies have been combined. Nor, when many studies have been conducted for a specific topic, does the clinician necessarily want the details of one individual study, because it would be inappropriate and less helpful to focus on only one. Synopses are often written as critically appraised topics, or CATs, as they are sometimes called. They are available in publications such as the book Clinical Evidence. Other resources are online, such as infopoems, patient-oriented evidence that matters, and PEER, which we will talk about when we discuss the synopses in more detail. Clinical practice guidelines also fall into this synopses category. The highest level in the hierarchy, systems, refers to decision support systems accessible through electronic health record systems. Clinical decision support systems are designed to facilitate the decision-making process at the point of care. These systems are most effective when clinicians access evidence-based information when they are making clinical decisions. This is the highest level, knowing the context of patient care and providing the evidence to the clinician to use in providing clinical care. How is evidence-based medicine applied? The steps are listed on this slide. The first step is phrasing a clinical question that is pertinent and answerable. The second step is identifying the evidence to address the question. The third step is critically appraising the evidence to determine if it applies to the patient. We spend less time discussing critical appraisal, although we'll go into more detail about it when we talk about interventions. However, all of the references listed earlier on slide 4 describe the process of critically appraising the evidence. The next few slides discuss phrasing the clinical question. One way to view clinical questions is to distinguish between background and foreground questions. Background questions are general kinds of questions that come up in the care of patients, and they are usually answered without using evidence-based medicine techniques. We look them up in a textbook or perhaps seek out a more classic review article rather than a systematic review. Foreground questions are those we ask when we need knowledge about managing patients with specific disorders and we're contemplating a test or a treatment. These are the questions that are usually answered with evidence-based medicine techniques. Let's explore background questions further. Sometimes background questions ask for general information that is not specific to a given patient, such as, what causes pneumonia? What are the usual causes of pneumonia, such as bacteria, viruses, sometimes chemical pneumonia? Are there other possible causes? At what stage of the disease do the complications of type 1 diabetes usually occur? In what order do complications such as neuropathy, heart disease, and kidney failure generally occur in type 1 diabetes? It turns out that the distinction between background and foreground questions is sometimes blurry. For example, there are new etiologies or causes of disease that you may want to know about either as background or foreground. Your level of training also may determine whether your questions are background or foreground questions. If you're a subspecialist, you may tend to ask more background questions, whereas if you're a student and nearly everything is new to you, your questions will tend to be foreground questions. Although the distinction is blurry, it is important to understand a clinical question and how to phrase a clinical question to find the best evidence. This brings us to foreground questions. Foreground questions have 3 or 4 essential components. One way to remember these components is the PICO acronym. A complete foreground question has a patient and/or problem, P. It also has an intervention, I, such as a treatment or a diagnostic test. If applicable, it includes a comparison intervention, C, and then it includes an outcome, O. If the question asks about a treatment, for example, it presents a patient or patient group with a specific disease and examines administration of a specific treatment or intervention. If we are looking for evidence, we try to do a randomized control trial that compares that treatment with a control or a placebo group. Finally, the question searches for some kind of outcome. The treatment is either more effective or less effective than the control or placebo. With a diagnostic test, we may look at how accurate the test is, so we compare against a generally accepted gold standard. If we are investigating prognoses, how patients do, we may not necessarily have a comparison, in which case we follow the natural history of a disease. Here is an example of a foreground question. In an elderly patient with congestive heart failure, where the heart is not pumping as strongly as it could, Are beta blockers, which are a type of drug, helpful in reducing morbidity and mortality without excess side effects? Most clinical questions fall into one of four major categories of foreground questions: intervention, diagnoses, harm, and prognosis. The first category is called an intervention, although many textbooks call it therapy. This category looks at the benefits of an intervention, such as treatment or prevention of disease. Diagnosis is when we look at some way of diagnosing the disease, typically with a test. The tests we commonly think of are blood tests, but any type of maneuver on a physical examination is also a diagnostic test, as in an X-ray. Often we want to know what caused a disease, which is sometimes called the etiology of the disease. In the evidence-based medicine category, this is usually called harm. What causes harm to a patient? Sometimes harm is caused to a patient in the form of an intervention, and we may do studies to look at that. And finally, the last question category is prognosis. What is the outcome of the disease course? When we find a piece of evidence, a study, we ask three questions. Are the results of the study valid? Are the results important? That is, do the results show that some treatment or test is efficacious? And can the results be applied to patient care? We also have to determine whether the results of a study can be applied to a specific patient. If the study was done with a different age group or a different gender, the results may or may not be applicable. We may ask many sub-questions within these three broad categories depending on the type of the main question, such as whether it is an intervention, diagnosis, or harm question. We also may ask different questions based on the type of study we are looking at. We may have a systematic review, for example, or we may have a randomized controlled trial. In the next few lectures, we examine the different types of clinical questions, how we look at studies, and how we appraise evidence that answers the clinical questions. This concludes Lecture B of Evidence-Based Practice. In summary, there are many easily accessible resources for EBM. The approach has changed over the years and is best viewed from the 4S model, demonstrating the hierarchy of evidence, based on a foundation of studies brought together where possible by syntheses, summarized in synopses, and implemented in systems that make it actionable. When seeking evidence, it is critical to appropriately phrase the clinical question.